Thanks everyone for coming, and thank you, Dr. Lindsay Puckett, for being our speaker today. She's an assistant professor at the Medical College of Wisconsin, so I'll let her go ahead and start, but just wanted to mention that if anyone has any questions, you can ask questions in the chat or also raise your hand through the Zoom feature.
Great. Thanks so much, Amy, and thanks for the invitation. Today, I'll be giving the second part of the prostate lecture series for IMRT. The first half was given by my colleague, Dr. Mac Longo. So if you weren't able to be there for it, it'll also be helpful to check out, and there's a few things that I'll reference that are similar. So today I'll be going over some prostate contouring basics, including normal structures, the prostate itself, and nodes. The last lecture, I think, was sort of a bigger overview of everything in prostate. Here I'm going to hone in a little bit more and go into the nitty-gritty of contouring and hopefully provide some tips that are useful for day-to-day. As far as disclosures, I don't have any financial disclosures related to this talk. I'm a radiation oncologist at the Medical College of Wisconsin. I also practice at the Milwaukee VA Medical Center, which is for veterans in the US. And so between those, there's different resources and different machines that we use. I do have a little bit of experience with global health and was fortunate to be able to go to Botswana in 2018, where I learned a little bit about practices there. And that group was in the process of transitioning from 3D to IMRT. So this is where in Botswana, their system is that you have a tertiary hospital, which was the Princess Marina Hospital in their capital. So we got people from across the country there. And then the LINAC was at the private hospital. So people were then referred over to the private hospital for their treatments. They had a single LINAC, which treated about 45 to 60 patients a day, depending, as well as HDR. Here you can see this is what they used for prostate. It was a leg board. And so I put two slides in just sort of to compare and contrast, because as we're going into IMRT, one important thing to consider is how are you setting people up and how reproducible is your plan. So as I mentioned, they were doing mostly 3D and some IMRT. The majority of their prostate cases were intact prostate, but there were some that were post-operative. Most of their patients were treated without nodes. However, some were with nodes. And for IMRT, since you're being more tight with your margins, one of the most important for prostate is bladder. And if that bladder is not full enough, their policy was basically if they saw that, then they would just simply rescan the patient again, put them back in the queue for treatment. If it wasn't the second time, then, with so many patients to treat per day, you just don't really have a lot of options. It's either you don't treat them or you do. So typically they would be treated in that case, but it really brings the importance of bladder filling and then also ideally having a more empty rectum to the table. Typically the dose they would use is about 74. And again, that was mostly 3D technique. So at the Milwaukee VA, we are typically doing IMRT now. We often will use hypofractionated treatment. Occasionally we'll use SBRT or SABR. Most of our patients are also intact prostate, but we do treat post-op as well. We see a lot of high-risk patients over at the VA. It's just our particular population, so a lot of them do get treated with nodes. For mobilization, you can see here on the side, well, this is a little bit fancier than the one that we usually use, but this is off the internet. So this is a vacuum bag and it's per patient. So you can really get a nice immobilization with one of these. Basically it has tiny beads in it and you suck it out. And so with our margins, that comes into play. And I'll talk about that a little bit more later. For our practice, we do check their bladder before their treatment. If it's not full enough, generally, we will also try and take them off the table and rescan them later. Occasionally, we will send a patient home if it's really not lining up at all. For our doses, we had a spectrum, and I know that was one of the questions from before. I don't think, I think you can go by the NCCN guidelines, and there really is a variety of ways that people practice in the US and abroad. Typically, if we're doing a conventional treatment, which would include nodes, the dose that we would use in total is ranging from about 75 to 79 gray. And typically we'll either do 45 or 50-40 to the nodes. In the post-op setting, we'll often go somewhere from 64 to 66. just as a caveat, we do often use the hyperfractionated treatment, which is an option, I would say, for any programs, and obviously everyone's a little bit different in where they're at and where their program's at right now. But if you're first just getting to learn IMRT, I would suggest sticking, if you can, with conventional to sort of get it into the workflow before you go to hyperfractionated treatment, as there can be more toxicities if you're not able to meet constraints. So for prostate contours in general, we have a lot of resources. There are several atlases. In the United States, we tend to use RTOG. There's also others from across the world. There's a frog atlas, which is out of, I believe, Australia and New Zealand. There's an EORTC. So there are other resources. These are some of the ones that we were able to bring in and do have as part of the RCC series. So some of those atlases are available. eContour is also a really great resource if you're newer to prostate contouring. They do a nice job of outlining the anatomy. Many people use books. I know when I was in Botswana, there's a treatment planning book. I also like Nancy Lee has a contouring book, which was my go-to as a resident. And sometimes I'll still pull it up when I'm practicing. And then the last one I would say, which once you've started to get the hang of things, there is a McLaughlin paper. Again, it's in the resources here. It's just common contouring errors when you start prostate. It's a region where the densities are really similar on CT. So it's easy the first few times you do it to sort of feel like, oh my gosh, how do I know what's what? And so I'll also go through that today. So one other tip, if you are just starting out, or, there's a ton of abbreviations that we use with this, as well as specific nomenclature. There's a nice lecture that Dr. Lee put together, and I have referenced here on just some of the basics of contouring. When doing prostate, structures will run into each other. So starting with normals is also a really great way to start. There's a program, Prono, which I don't think was used so much last week, but I'm going to spend some time with it this week. And again, I encourage you to use an atlas and the protocols. They're really helpful along the way. And that's whether you're at a beginning stage or if you've been doing this for a while. I still use them myself. So one of the more helpful ones is this RTOG atlas, which we do have in there. So generally, where do we start? One trick I always tell my residents, and I use frequently myself, is using the crosshairs. So what do I mean by that? I'll go into Prono and just show you. But this is one of the best tips, no matter how hard it is. If you use all three of your dimensions that you have, the axial, the sagittal, and the coronal, you can really pinpoint where you are in a number of cases. Some of these structures go for up and down, and so tracing them too before you start can really help to make sure you're confident in where you're going and limit what you have to redo. So I'm just going to switch over to Prono. Okay, and can everyone see this? Are you seeing the Prono case right here? Okay, great. So what do I mean by crosshairs? So each program that you have for contouring is probably a little bit different, but has the same feature. Here they call it slice navigation. But for example, if I was looking at the bladder and the rectum, right here, it can be tough on a slice. You can see here that there's a slice of bowel sitting right on top of the bladder. So if you're starting at the top of the bladder and trying to contour, you might start here as the top slice of the bladder. But once you move the crosshairs to that point, you can really see where it is. This also comes into play, for example, if you're doing the femoral heads. Well, it kind of looks bulky here. I can't really tell, is this the top of the femoral head or am I above it? And here I can see that I'm actually above it once I go into my other planes. And so sometimes scrolling through those can be really helpful as well. The other thing is window and level. So this program has a little bit less with window and level. I was playing with it, and I apologize because I'm a little bit new, but you can sort of tweak here. So just by tweaking it a little bit for bone, if I was going to do the femoral heads, now I can much more clearly see what the boundary of this is and where to contour and what's above it. So those are just a few general tips. Okay. So again, I encourage you, if you didn't have a chance to go back to Dr. Longo's recent lecture as well. But I'm going to start with a few normal structures. For the purposes of my talk today, I have structures that are incorrectly and some incorrectly. I'll walk you through everything, but it's really a learning opportunity. And at the beginning, when you're first doing this, or even if you've been doing it for a while, sometimes it's frustrating feeling like, well, is this the right thing to do? And obviously you want to treat the patient right, but everyone's learning and everyone does things just a little bit differently. So just using your resources and doing the best that you can is the right way to go about it. So I'm just going to review a few things here. From the RTOG Atlas, they define inferiorly the lowest extent as matching up with the ischial tuberosities. And here you can see this is the lowest slice, and we'll review what that looks like. And that's often a good place to start. And then superiorly, they mention going up until it loses its round shape. Some others will use the rectosigmoid flexure. So let's go see what that looks like. So I'm gonna bring this back to just my regular levels, and there we go. So I put some of these in to begin with, but so rectum, there's certain slices where the rectum's really easy to delineate. And then towards the bottom here, this density is very similar. Sometimes a window and level can help a little bit there. And so I'll just see if I can tweak it ever so slightly. That might be a little bit better to me. I think I can visualize it here. And so in the interest of time, I'm not going to go through everything exactly, but we have a rectum on here. And they've gone, and here you can see the bottom slices of the ischial tuberosities inferiorly. It's gone similar to my recommendations before. I'm going to put my crosshairs on it and see what that looks like. And that's surrounded by muscle. So you don't need to include all of that in your rectal contour. And coming up here, it can be really tricky right here with the prostate and the rectal border. So just sort of pinpointing here, where is my boundary? And oh, good. So now I have a clearer picture of where the prostate is and where the rectum is. And if you don't put the rectum on first, one challenge that you can run into is that the prostate and the rectum will overlap in your initial contours. You don't want to have those two GTV structures or GTV and organ at risk structures overlapping. It is okay if it happens for the PTV, and in fact it will, because the anterior wall of the rectum is immediately adjacent to the gland in the middle slices here. So that will happen. I have on here, sorry, just bear with me. Here's a prostate gland, just for an example. You're going to run into trouble when you're meeting your constraints if I've just been basically a little bit too generous on this prostate here. So you can see that they're overlapping. And philosophically, it's also important because you need to decide what is most important to you. If you think something is at risk, then you're going to want to make sure that that's covered with your beam arrangement. If you decide that it's less risk or not at risk, then you have to balance that. But your dosimetrist or physicist won't be able to give you the best plan if these are overlapping in the initial. So what I would do is, I think, like I said, that this is being overly generous. So I'm going to come back and actually trim this a little bit more to the back of the prostate. One other tip is to do every few slices before you do every single slice. If, for example, I do this one and then I have this one and it's jagged like that, that's going to affect the quality of your contours as well. So sometimes at the beginning phases, if you're less familiar, just having every few and then going back to adjust can be a more effective, time efficient and effective way of doing it. Okay. So I'll just tweak those and I would go back and then tweak. So I've defined here which is which they'll need for planning. So let's see, one other point for the rectum is the contouring atlas will mention the last round slice. So we're here, we're going up. And then this this particular rectum does a weird thing where it goes to the side here. And so what's the last round slice? I mean, you might say right here. When I put my crosshairs here, though, that doesn't look right. That's still in line with the prostate. That's too low for the rectum to be done. So in this case, using the rectosigmoid flexure, and what happens there is the rectosigmoid flexure is where it starts to dive anteriorly. So you can really see it nicely here, and it comes off. Many of the RTOG trials also use this as a definition. And everyone's anatomy is a little bit different. I would say almost all rectal contours will have that sort of, you can just see it dive anteriorly, and it might be anterior and to the side, but that's the most common for anatomy. So again, you have to evaluate the patient that you're given, but I find that to be a little bit more helpful in general than the last round slice. So I think that covers what I wanted to go over for rectum. Let me just bring this. Oops. Okay. So a few other points just to mention. Be careful at that glad. I'll change that to gland section. You can be glad about it too, that's fine. But if, as I mentioned, you don't want to overlap in your GTV, and the prostate is the rare area where your GTV is the whole gland. So that's not really your gross tumor volume, but because we don't know exactly what it is for the purposes of trials, they generally call it the GTV. And again, if you're unsure, use those crosshairs. So let's go on to the bladder. For many, the bladder is a little bit simpler. A few points, it can get tricky towards the bladder and neck. And then sometimes actually at the very top slices is a little tricky too. Here you can see one where it's in the middle of a pile of bowel. So let's see what that looks like, our contour. Okay. So here, if I'm just looking here, I'm going to put the crosshairs in an unhelpful place just for the purposes of looking through. And people will probably have different programs that they're using for contouring, but one nice tool for the bladder is you can use Hounsfield units and density to sort of delineate it so that when you're contouring, instead of just like I'm doing here with a paintbrush where it can kind of go to the outside, if you're using that tool, it can kind of crisply delineate it and you can go a little bit more quickly. So I like to start in somewhere in the middle and then get my boundaries. So by scrolling up and down, I can see that to me, this looks like my topmost. And then coming down here, you can see that there's a different density in here. So what do you make of that? Sometimes you might say, oh, that's the prostate, or oh, that's the bladder neck. But the truth is, it can be really hard to tell between the two. I have sort of a nice slide that I'll go back to here. So this is from that McLaughlin paper, which I'm always touting in this talk, I think, but just to show, so this is your CTs and your MRIs over on this side. So you don't have to have an MRI for it to still be useful. You can see here, this is a case where there's prostate, and if you really squint hard, you might be able to see that there's a different density there. And again, window and level can help. On this case, you can pretty clearly see this is the bladder neck. But if you look here, you really can't tell with that density. So that's where what I was talking about with using the crosshairs comes in. So in this patient, I might have decided this is the bladder neck, but when I put on, my crosshairs, now you can pretty clearly see that this is sort of an enlarged prostate that's actually going into the bladder. So I'll just put on the bladder structure that's here, and they've done a nice job of that. I turn off prostate 2 because that was my dummy prostate. But here you can see this nice large prostate and where you can imagine that it exists. So this is one of the most common errors in contouring prostate, is to skimp on this section. Sometimes, depending on the biopsies that you get, you may have a good sense of where the disease is, if it's or if it's at the apex, or if it's at the base, or if it's diffusely throughout. However, if you only have one or two cores to tell you that it's prostate cancer in the first place, then you really need to be generous and make sure that you're not missing any gross disease. So if in doubt, you do want to include that and not be too skimpy in those areas. Okay, so just coming back here. So just to summarize, a lot of these are easy after you've done them once or twice, but be careful at those superior slices at the neck. It is coming in at an angle. We're so used to looking at everything on axial slices, but that's not necessarily as helpful. And even though you can see fluid, there is musculature, which appears a little bit more dense. So be careful. And lastly, sometimes windowing and leveling can really help there. So bowel. Bowel is its own complicated thing, and you could probably spend a good chunk of a lecture on the tips for contouring bowel. So in general, I'll just raise a few points. You're going to start your bowel for contour at the same point where your rectum ends. So you're coming up here, to bowel, and that'll go on. And typically what you do with these protocols is actually a bowel space or a bowel bag, it's sometimes called. Different protocols can go in different ways. So whatever you're using as far as your constraints, just pay attention to that, whether it's something that's designed for a bowel bag or whether it's specifically for colon or small bowel. You might wonder, well, why don't you tell me which one's right? And the truth is there's a lot of different ways to do it, and different institutions will do it differently, and there's a lot of factors that go into it. So I for the purpose of this lecture, I can't tell you which to do, but just that you're being mindful of where it's come from and specifically what you're looking at. For this case, I did want to point out, so if you're above your target and looking at bowel, it becomes especially important with lymph nodes. In this patient, they were able to use oral contrast, so it can really help to delineate. But you might see here, let's see here, and I'll just turn off this. But right here, well, what's this? Is this a slice of bowel or is this a vessel? And having that contrast, if it's available, can help, but you can still find this either way. So I'm looking here, putting on it, and here I can see, oh, well, this is contiguous and it doesn't seem like it's going in a bowel direction. I can put my crosshairs here, and here now I feel very comfortable. Oh yeah, this is the vessel. This is not a loop of bowel that I've missed. All right, I think we've covered all this. So penile bulb. Penile bulb can be a little bit tricky and people contour it somewhat differently. The thing to remember is that it's prostate, GU diaphragm below it, and then the penile bulb. It's typically at the level of the base. So let's take a look at that. So coming down here, this is the base here. And so one other thing that's important with prostate and penile bulb is sort of the shape of it. Once you've done it a few times, you start to see this globular shape that's common, and I'll show a few slides of that as well. But I know that generally it's round to sort of a light bulb type shape that's here. So I think I can delineate it, and I'm expecting round, and I would probably say that this is a little bit more round than this. So expecting that round shape, and there is some tissue around it. And this person had also contoured the penile bulb, and to me, this is a little bit low. So I don't see any bulb left at these slices. So I would probably get rid of it. And again, looking on here, I'm expecting to see sort of a round shape in a setting that it's below the prostate and there's a separation for the GU diaphragm. So that looks about right to me. So I'll leave that there. And proximal femoral heads, I think we touched on those before. Again, some contouring systems now have a bone window where you can sort of line it up. Sometimes you can get artifacts. So if you are using any sort of software that's sort of doing it for you, just be careful that it's done a nice job and actually captured what you want to capture, because there is a lot of room for artifact that can be problematic. So let's move on to sort of the mainstay. So that prostate itself, contouring intact prostate. So in general for IMRT, this is going to be somewhere between 180 centigrade to 200 per day. Again, hypofractionation has some other considerations as well. And in general, so I have a couple different reported protocols that are in here. That's the ideal way to choose your constraints, is from something that's published already. And I'll put some of those up as well, but they are available in the resources here. One of them is from 0815. So for the purposes of that, as I mentioned, the GTV is defined as the prostate itself. For your CTV, so that's your clinical tumor volume, that's defined as the prostate plus the 1 cm of the seminal vesicles. And that's in the seminal vesicles that are in the same plane as the prostate. And then your PTV is going to depend on what your immobilization is, and that should be done in concert with your physicist, who will help you to know what's the appropriate amount there. Sometimes in prostate, people will use an asymmetrical expansion. So you'll often see something like in Botswana, we typically used 10 all around except 7 posteriorly. So if you're using something like that where you're going asymmetric, the idea is that you're lining up specifically to that structure. So we had already looked a little bit at that prostate rectal interface. And so when you do your planning, that should be right on if that's what you're going to use. Here's a few of the basic constraints, and these are volume constraints from that study. These are outlined here. One to note is it's good to track the penile bulb, and if you can spare it, to do so. It's associated with erectile dysfunction. However, in the end, we do want to cure the prostate cancer. So if, for example, you can't meet that measure, unlike some of the others where you have to consider weighing it out a little bit, in the case of the penile bulb, you shouldn't compromise. You should still treat to the dose that you need to do, but just track it. If you are planning to do hypofractionation, for those who are a little bit more familiar with IMRT and moving beyond, the NRG 005 constraints are in here for your review in the resources section. Some others, just again, these are examples. However, they're pretty conservative for our institution. Another where I practiced used 10 cc's instead of one cc. Quantec is a great resource for some general ones, but otherwise, I think it goes with your experience and your institution. I can't prescribe on these specifically. So I'm going to go to the intact case. As you saw before, there's some errors that I purposely put in just to review, because they're things that we all struggle with as we're doing this, and truly some of it is using quote unquote the force rather than a specific boundary at cases. And in atlases, sometimes you'll see the MRIs. If you don't have MRIs at your institution, or most of your prostate patients aren't going to have MRI, that's fine. You don't, even though they're a helpful resource, you can still benefit from the atlases in terms of seeing the shape and getting comfortable with it. One other question that I heard was asked pretty frequently on the last talk was seminal vesicles and lymph nodes. So these are tough, and if you're using Contra, if you're using any of the other resources, truth is we're still learning. The data is evolving, and these are good questions for example, a chart rounds versus a blanket statement of, oh yes, you should always do this or always do that. But here's a few typical rules that I would say. So for seminal vesicles, if they're involved, you're going to include them. If you have a high suspicion of involvement, and there's different ways to calculate that, including some tables, you're going to want to include them, or at least consider including more than 1 centimeter of them. For high-risk disease, some institutions will include the whole seminal vesicle, some will include 1.5 centimeters. There's some data for that, but it is based on your perception of the risk. For low-risk disease, in many cases, the seminal vesicles are not treated or aren't largely included. There's often about 1 cm that's like really abutting the prostate itself, so it may not be that much extra. But as a philosophy and as a target that you're treating, we don't generally think of it as much with low risk. So lymph nodes, I would say, are very controversial, and thankfully there is research and data that should be coming out on whether we should or we shouldn't. If they're involved, obviously you're going to include them. And if you have a high suspicion of lymph node involvement, again, I would strongly consider including them. For high-risk disease, we typically will include lymph nodes for all our high-risk disease. For high intermediate, there was recently a trial which I believe is now closed, which is looking at it in this population. In general, at our institution, we don't. However, if there's a very high suspicion, I do have select cases which I treat. Others often will for their higher risk, high intermediate risk. For low risk disease, I can't really ever think of a reason why you would include them. And obviously, if you're concerned that there's active lymph node involvement, then they're probably not low risk disease for the most part. So again, this McLaughlin paper, this is a really nice illustration to show, again, just how there's muscle above and below the prostate itself, and we have to take that into account. So let me go back to my case. So for the prostate, and I'm going to just turn off some of these other structures. We helped ourselves by having the bulb on there, and then we know it's coming to the GU diaphragm. So the GU diaphragm has a fat plane, and you can kind of see a fat plane here. And if I squint at it, and the one time where the crosshairs can become annoying is when they're in your field of view. So if that happens, just move them off to the side. But here, you can sort of squint at it and see it. And depending on the quality and the image slice thickness of the prostate, sometimes you can see a little bit more or less. So I'm going to go back to this. This is really helpful to me, and I go back to it frequently. So looking at the shape of the GU diaphragm, and again, you can't see this for all the cases, but at the bottom, you can clearly see these fat planes here. Here, I don't see the fat plane anymore. In the middle, you can kind of make out this circular shape, or I hope you can. And then the last one, they call this a slit or an hourglass, but man, that's tough to see. I feel like it's a little bit of a reach, kind of like constellations where, oh, I see that there. You know, there is this sort of, you can see the fat above and below right here. And then right after that, you get to the first slice of the prostate. So let's go back to our case, because all these tips are fine and good until you go to your case and all of a sudden it doesn't look exactly like the textbook. And it's like, well, can I make that out? What am I seeing? So we're here, and, you know, I can see right here, this looks like mid to meat, where I can kind of see a circular shape. So one slice above that, I should be at the slit right here. And one slice above that is where I would begin my prostate contouring. So this person's contoured a little bit generously in here. And again, what I was talking about, the density. So you can see here, what I'm including is not the whole of this space that's all similar density. I know that this area is surrounded by muscles. And let me see, if I switch over, are you able to see this where it has the E contour? Is this coming up? Can anyone give me a nod or a no? I might need to switch. Let's see here.
Yeah, I'm still seeing the reflection.
Okay, let's see here. Here, how about now?
Yes, I can see it now.
Okay, great. So here you can kind of see, and they've nicely laid out. So here's the muscles coming around. You have your rectum back here, and there's vessels often in front. So it's not going to be adjacent to the bone. And this is a little bit further up than the slice I was showing you, but those typically will not be in there. So that's where using an atlas really helps to see sort of where your front border should be, and giving that little bit of space that if you do have an MRI, it becomes more apparent, but we don't always have that. So I'm going to go back to my case here. Okay, so here you can see my muscles, and I'm going to say prostate here. Now, again, this one's just a bit generous to what I would normally do. And we can see that they've just been a little exuberant and kind of come into the rectum here. So there is a typical shape to the prostate. I have another prostate as well here. And typically it doesn't come down quite to this extent. So I'm just going to crosshair here. So as you're starting to look at the prostate, it's a globular structure. So this on the sagittal over here, this looks nice. But here I'm a little concerned. It looks like it's tapering off so much. So to me, shape-wise, that's probably not prostate. And I think they've gone a little bit low actually into the GU diaphragm, just a little bit on this case. Sorry, I'm just getting back to my slideshow. Okay, here we go. Any questions on any of that before I move on? And if not, we have a couple, thank you, Amy, for moderating, and I know I have a couple residents on as well. If there are, feel free to interject if there's something pertinent, otherwise we'll save them for later on. So again, this is a good example where it kind of shows that characteristic shape that I'm expecting to see, where it's round, and it's coming down and it tapers, but not completely to a point. Prostates are different in size, so this actually looks pretty similar to the case I'm working on today, where it's an enlarged prostate. Sometimes you can have one that's so small that you're like, is that it? Is that really all that I'm contouring? So do be mindful. We say all these things that there is separation, but it's different from case to case, and everyone's anatomy is slightly different. And with experience, you'll be able to recognize a little bit more. These, I think, are some really nice pictures. This is someone similar to the case that I showed where they kind of came down and created that sort of cone on the bottom. Here they've included this GU diaphragm. This is on MRI versus the round section that you can see is actually the prostate. Here we've gone and included the rectal wall, similar to the second case that I showed. And again, you're tipped off to it if you're using your crosshairs, because it's like, well, wait a second, that just doesn't look right when I look at the shape of that. Generally, we think of it as behind the symphysis, but that does vary a little bit. So while we can use it as somewhat of a marker, it's not your be-all, end-all. And then lastly, that plexus. So you can see here that there's vessels, and this is kind of a nice crosshair slice. So I won't harp on this too much more, but just be careful of overestimating anteriorly. So at the base, the same thing, and we talked a little bit with the bladder about being careful to avoid the neck and looking at the shape there. And, I'm just going to touch on seminal vesicles too. Oops. Oh, sorry, I lost my, oh, here we go. Okay. So back to here. So the seminal vesicles blend in with the prostate right around here. So what I like to do is start with them, and you can go centrally to see sort of where they're going from the prostate. Some people have big fluffy seminal vesicles, and sometimes they're smaller. So what I'll typically do is, and I really recommend this for when you're starting out, is to contour them. And instead of just doing the proximal, do the whole thing and see what that looks like. So I'm just going to add in here. So seminal vesicles are coming out here. And coming out here. And by going from above and coming down to the prostate, it becomes a little bit more clear what's the prostate and what's the seminal vesicle, where otherwise, and here again, there's no plane. So sometimes I'll see something like this where it's just been connected in the back, and you can check it. And that looks pretty reasonable when I'm looking at it on here and checking through. Okay. And I won't talk too much about it, but typically how they're combined is with a Boolean structure. So it just brings the two together. Some people will use an auto expansion on their prostate to get the 1 cm. Other people, if you know the thickness of your slices, will just use, for example, if it's 3 millimeter slices, that's going to be 3 cuts above and below is how much of the seminal vesicle you'll include in that CTV. Okay. And at the base, yeah. And overall, you know, if the slices are a little wonky, their tools are improving in the contouring atlases to help smooth a little bit. Be careful about using a smoothing function, or you can miss the top and the bottom once it smooths. Some of them have what's called an autopilot, where once you have your slices in, it can show you what would be in between. And that can be really useful to avoiding those big changes superiorly or throughout the contour. So I think we've touched on a lot of these. We're going to use the GU diaphragm to define the apex. And some people recommend starting there. If you're just having trouble at the apex, then go to the middle of it and go at a slice that you're confident, and then go back to where you're a little bit less confident. And I'm briefly going to touch on nodes as well. There's a new contouring atlas that came out this year, which defines it ever so slightly differently than some others have in the past. But generally, your contours for prostate for nodes are going to start at L4, L5, but it really is the bifurcation of the aorta. So let's just see what that looks like on our case. So and typically what I'll do here, sorry, I'm just going to make a new structure. Well, actually, I'll use a structure that I already have. Here we go. Okay, so one of the easiest ways to start is if I'm looking for L4, L5 interspace, I'll actually go to that and click on it here, and I know I'm at the right level. But we talked about really the way you want to do that is the bifurcation. So if I would have started there, I would have missed right here, we see it bifurcate. So this is actually the proper place to start the nodal contours for this patient. And the reason for that is because it's the vessels that you're tracking along, not a bony anatomy that's truly what's putting them at risk. So we want to cover that whole nodal region. And one feature it has here, and other systems will have this as well, is this brush diameter. So for nodes, in general, you want to go 7 millimeters around, excluding bone and muscle. So an easy way that someone had shown me to do this is to use a brush, which is 7 millimeters in diameter. So by doing that, I can come here, and if I go around the nodes or around the vessels in the space, and again, I'm not going into muscle and I'm not going into bone, and depending on the features of your system, there can be a hard edge that you use here too, so you don't have to go back and manually edit quite so much. But then I've mindfully gone 7 millimeters around. Now you have to be careful if you're doing it this way that you're not getting sloppy and going too close. And also if there's somewhere that's at risk that needs a little bit more, the newer atlas suggests going more like 10 millimeters or 1 cm anteriorly. So here that looks like a reasonable thing to do. So I'm increasing it a little bit more. And coming down, you want to be careful not to miss in by the musculature here as well. I pointed out this before where you're looking at it and it's like, well, hey, this is asymmetrical. You know, is that my vessel? And by tracing it, we learned it was. But you can see they're just, the two vessels dive differently each side. So here goes up this way, and here, when we watch the vessel, here it goes, and it goes this way. So the first few times you do this, and even after that, it's just helpful to see where the vessels go to begin with, and then you'll be sure not to miss them, because often they don't have contrast, and so it can be tough to tell the difference. So coming down just a few points, so typically it's around S3 that you're going to cover back until, and then it starts to separate, and I'm just going to show that. Here we go. So yeah, going from roughly L4, L5 down to about S3. And again, you're not going to want to go into the muscle or bone, because once you expand on that, you're really enlarging the volume that you're taking the nodes. One other good tip is sort of where to leave off. So we mentioned those vessels kind of diving forward. If you put the crosshairs on it, you can see the inguinal canal here. And so that's when you're going to leave off chasing them anteriorly. And I'm not going to spend too much time here. I know Dr. Longo had gone over this as well. So, one other thing to be mindful of is we talked about doing every few slices. With lymph nodes, you're changing planes so much. So if you do something like that where you're interpolating between slices, make sure that you go and clean up. Otherwise, you can end up including bowel or bone or muscle in your volume for those. So, now you got this. You're a contouring pro. I know everyone's at different stages as far as their clinics and where they are. So what do you do next when you're comfortable and you want to bring this in? And obviously it can be very helpful for the right patients. Before you can start, you have to have your IMRT and your QA, which is a very important point for us when we're using IMRT. It'll often take us, a week or more to get the plan together because it has to go through extensive physics QA, as well as the planning takes a little bit longer. So if you're starting putting this in practice, a great way to do it is to take your 3D cases, also do the contours and have both plans, and then look at those side by side to see what you're getting. You also want to work with your dosimetrists. What looks like a good plan for them and what looks like a good plan for you may be a little bit different. Be mindful that there's not any hot spots outside the area you're treating centrally. And there are resources, which I'll go to in just a minute, to help review some of those as you're getting started. And then the therapist. So this is a different idea. If you've normally been giving a big PTV margin, your prostate's going to be covered and, you'll cure their cancer. So that's a fantastic thing. And as our technology improves and we're moving to IMRT, what we don't want to have happen is, the prostate moves a lot each day, and depending on bladder filling and rectal filling, it can be really different. So you want to make sure you're comfortable and the therapists also appreciate how important it is to get them lined up in exactly the same position in order to minimize those toxicities. So with workflow, some of you may have departments where urology might be willing to do fiducials for a case. If you were thinking of doing IMRT, it's a nice way to know exactly where the prostate itself is. As far as planning, I mentioned our process usually takes 1 to 2 weeks. At least in my experience in Botswana, and I would suspect it's the same for many of you, is people were coming from all over the place. They were leaving their families to get this treatment. Anything that prolongs treatment is really a big ask. So, for the right patients, I think IMRT can be a great idea. But if you're going to terribly inconvenience them or it's not feasible for social situations, it's not wrong to do 3D. We have good evidence for 3D, and ultimately you want to do what's going to get them treated in a timely manner. So, and I think I harped on it already, but make sure you're comfortable with your plan, that the physicists are comfortable with your plan, and that you're adding a big enough margin, especially when you start out. So overall, IMRT is a team effort, which I'm sure all of you are aware of, and doing some practice cases can really help to move it into clinic comfortably. With contouring, actually, perfect should be crossed out here. It does not make perfect. We all make mistakes and we all review. At our hospital, we have a contour rounds, which we do prospectively. So before the patient is treated, and we'll make comments like, oh, it looks like the penile bulb isn't covered, or, do you need to go a little bit more anteriorly there? And getting comfortable with that feedback. If a large group of radiation oncologists contour these together, each of them is going to have a slight difference in those contours. So you're not doing it wrong. It's just a matter of getting comfortable and doing the best you can to be proficient. And we have a lot of resources here, so really use them. And then the last thing I'll say is to phone a friend. So on my challenging cases, I'll frequently reach out to, for example, Dr. Longo and be like, you know what, can you take a look at this with me and just get their feedback on what you're including or not including. So last few things, just a few plugs. There is something called chart rounds, which there's different groups that, and I assume different time zones. I have the link in here, but if you're practicing alone or with others who haven't really done a lot of this, or even if you are practicing with others who are very comfortable, it's a great resource if you don't have your own chart rounds to be able to log in and see some cases that others are doing. One other is this group, the International Cancer Expert Corps, or ICEC, and here's the link here. They do have mentorship programs, and there's some trials right now where sometimes they're linking up sites with a university site in the US or individuals if needed. And I know through RCC to stay tuned, they're working on some programs, hopefully in the future, for both the radiation therapists and also with contouring, which I believe is in the pilot phase right now. But if you're on the lectures, or if you're watching this after this lecture's aired, be sure to go back to them too, because that may be up and running in the future. And I have this blank, we'll fill this in on their website, just with a link to the resources that I mentioned. So thank you to the many people who helped me with this. I'm lucky to have such great mentors, and I learned so much from my experience in Botswana that has really impacted how I practice. So I truly believe in learning both ways. And, if I can ever be of help, happy to do so. We have several residents who have helped, thanks to the RCC group, and all of you for calling in. I'm happy to take if there's any questions.
I think there was just a couple of questions in the chat. Are you able to see the questions?
Oh, let me see if I can pull that up. Okay. Oh, okay, great. So let's see here. Yeah, so one of the questions is the prostate apex rounded off versus pointy. It is a little bit different. I would say halfway in between. Very pointy is pretty suspicious, and but in rare cases, it is the case that it is a little bit less of a round shape in general, and especially as you're beginning to do this, try and look for that rounding towards the bottom. I had a slide, and this might have been before I showed that slide too. I will go back to it and show that one if that would be helpful, but I'll just take these other questions first. Is there practice drawing rectal and bladder wall with a 5mm brush? So I typically don't draw. I would draw the rectal with somewhere around a 5mm brush, and the program I use just automatically fills in the center then. I think it just depends a little bit on the case. Sometimes I'll adjust the size depending on the size of the rectum and what's easier for, let's see, let me just go to the case real quick. So for example, if you have a really big round thing like this, sometimes it's easier to do with a larger brush versus something like this, it's easier to do with a smaller brush. However, it can get really finicky. Like if you go down as far as say like a 3mm or something to get it all, it just takes a lot longer. And while you do want to be accurate with bowel, you have to remember it's just a snapshot in time. If we get both a contrasted scan and a non-contrast, sometimes it's really amazing how much the bowel has moved in the course of a minute or two. So while I want to be as precise as I can, and especially in the regions like this where I'm adjacent to the prostate, if it's ever so slightly different on something like this, I'm less concerned. Well, I don't want to be that sloppy, but I think you get the idea. And with bladder, I generally would use one of the settings that allow you to do Hounsfield units, so it automatically does your boundaries because there's just such a difference in density here. If you don't have that and you're doing it on your own, I don't know if I'd prescribe. I'd say whatever you feel most comfortable with is probably pretty reasonable. Thank you. Oh, thanks for listening, Karima. I'm glad, a couple of you, thanks. I'm glad you enjoyed. And then send the atlas for contouring. Yes, so I'm not sure if I have anyone on from the RCC group. The one feature that I was gonna link is we have all these atlases as well as some of the protocols for the papers. And so all of those are gonna be available through RCC. Oh, thanks for the nice messages. I'm really glad it was helpful. I'll just go back to that one slice. Oh, we'll post these to the Google Shared Drive folder. So that's where you can look for those. And if I can, I'll try and update on my slides as well for a link there. But yeah, thanks everyone for coming, and I hope that this was helpful. I know everyone's at a little bit of a different stage, but yeah, I appreciate the invitation and getting to talk to you all.
Thank you so much, Dr. Puckett.
Oh, my pleasure.
And Amy, thank you very much as well.
Yeah, thank you, Amy, too.